Pulmonary venooclusive syndrome is another cause of pulmonary hypertension. This is a very interesting patient who presented with an area of consolidation in the right upper lobe. Note the presence of an air bronchogram. Differential diagnosis would be pneumonia, and we might consider some other conditions where air has been replaced by something like edema, hemorrhage, and less likely neoplasia. In this infant, the early phase of a pulmonary arteriogram shows flow retardation in the right upper lobe. If this was a pneumonia, we would have expected the perfusion of the right upper lobe synchronously to the other areas of uninvolved lung parenchyma. In a late phase of the angiographic examination, when we already have the left atrium opacified, note the poor opacification of the vessels of the right upper lobe. We have to expect asymmetric pulmonary blood flow and flow retardation when we have such a situation. In a late phase of the levoangiocardiogram, where we see the left atrium and the aorta, note the persistent visualization of the arteries to the right upper lobe. At autopsy, this child had isolated pulmonary vein stenosis of the right upper lobe. Etiology could not be established, but the sequence of angiographic findings are very characteristic of pulmonary venooclusive syndrome. If this was due to occlusion of the pulmonary arteries, we would have seen abrupt cutoff and the filling defects, which are the pathognomonic sign of pulmonary thromboembolism. When we regroup the causes of veno-occlusive disease based on frequency, we must start first with viral infections, then with environmental toxins, chemotherapy, autoimmune disease, contraceptives, intracardiac shunts, radiation injury, and genetic predisposition. We must also include iatrogenic causes like following a Glenn procedure or anastomosis of the superior vena cava to the right pulmonary artery. Any instrumentation that occurs in the mediastinum can lead to occlusion of the pulmonary veins. A number of hypercoagulable states has to be included also in this list. This gentleman, age 18, was admitted at the University of Miami School of Medicine teaching hospital with shortness of breath of about 3 months duration. He worked in a farm and noticed that progressively he was dyspneic. The frontal chest rentgenogram shows that the heart is not enlarged. There is some prominence of the pulmonary trunk and of the central pulmonary arteries. Note densities in the right base and some suggestion of right pleural involvement. Oligemic lungs were also observed. A close-up of the lung bases shows the ill-defined densities, particularly on the right side, but note that we have curly bead lines. This was not appreciated on initial inspection of the frontal chest rentgenogram. Also note the pleural thickening and the oligemia in the periphery of both lungs. Because this patient did not have evidence of cardiac disease, we would then have to explain why do we see evidence of oligemic lungs and signs of interstitial edema in the lung bases occurring simultaneously. This combination retrospectively is virtually pathognomonic of generalized or diffuse pulmonary venooclusive disease. The lateral chest rentgenogram showed the basilar changes and the prominent hyla that were the result of enlarged pulmonary arteries. When I catheterized the pulmonary trunk, very high pressures were obtained. Upon injecting contrast in the pulmonary trunk, one can see centrally enlarged pulmonary arteries, attenuated peripheral vessels, and the most interesting observation is the evidence of asymmetric pulmonary blood flow. Note flow retardation, particularly in the right lower lobe. In this later phase of the pulmonary arteriogram, one can see tortuosity of intrapulmonary arteries, particularly in the right lower lobe, and hypoperfusion of many areas of the lung. But at no time we could see filling defects nor evidence of abrupt cutoff of vessels. In the levoangiocardiograph, we can see opacification of the thoracic aorta, but persistent opacification of several intrapulmonary arteries. This means that there is obstruction to the pulmonary blood flow. Now, at what level is that obstruction? It could be precapillary, capillary, or postcapillary. The fact that the patient had curly lines in the lower zones places the obstruction at the postcapillary level. A very late phase of the pulmonary angiogram, when contrast was already in the aorta and its branches, we could still see persistent filling of intrapulmonary arteries and many areas of the lung that were not perfuse. Initially, the diagnosis was of multiple pulmonary emboli. Once again, we did not appreciate the significance of the curly V lines. The patient died a couple of weeks later despite adequate heparinization, and autopsy revealed areas of hemorrhage in the lung, the dark spots that you can see in this specimen, and evidence of occlusion of multiple intrapulmonary veins. Structural changes were also observed in the pulmonary arteries, such as medial hypertrophy. The final diagnosis was pulmonary venooclusive disease that could have been caused by a viral infection or some sort of environmental toxin. The etiology was not established. Retrospectively, the lesson that we learned was that in a patient who has evidence of pulmonary hypertension and exhibits radiographically signs of interstitial edema, in the absence of left cardiac disease, in other words, in the absence of a left atrial myxoma, mitral stenosis, left ventricular failure, we have to suspect pulmonary venooclusive disease as a cause of pulmonary hypertension. This is another patient who had the pulmonary veno-occlusive disease. The frontal chest rentgenogram shows a prominent vasculature bilaterally and a minimally enlarged heart. Curly lines were visible in the lower zones of the lung. A lateral chest rentgenogram showed the prominence of the pulmonary vasculature, particularly in the central portion of the lung. This is a close-up of the right base where we can see the increased vascularity and the presence of septal lines. Perivascular haziness was also apparent.